So as challenging as the previous discussion is what we'll talk about now, which is about how to treat these patients in this phase of time where we have incomplete and imperfect knowledge about what's going on and how to help the current ones get better. There is another issue about how to diagnose this faster and how to screen. And we're not going to address that because the patients who are in the room right now, who are waiting for your input, are the ones who already have this disease. And I think there was discussion of, and I'm going to just start off with highlighting some of them and ask them to come and share where they are in terms of their treatment and what's happening. Anna, are you here? Do you want to start off by just sharing in 3 or 4 minutes what's happening with you and where you are? Okay. Let me see. If not, then Regina, why don't you go? You talked about the Actemra reaction, but maybe start off from where you got imapalumab last year and to where you are now.
Okay, so we received imapalumab in July 2019. Prior to that, Juliana had her first CT scan, which we discovered and actually had the formal diagnosis of interstitial lung disease. So we arrived shortly after in Cincinnati with a very acute case of MAS. We received 8 infusions of Gamifant over about 4.5 weeks. And then we waited. We repeated a CT scan in September, and the CT scan had shown improvement. It looked very similar to the slide that Dr. Schulert had put up earlier. In fact, I was wondering if those were in Juliana's lungs. And that was a great sigh of relief, but we know we can't repeat CTs all the time. And then Juliana started to decline. We go back to Cincinnati periodically. We've repeated a pulmonary function test, well, a 6-minute walk. She's too young for the PFT, but she nails the PFT. She has clear sounding lungs. She doesn't have any, I would call her asymptomatic from the clinical perspective, with the exception of the advanced clubbing. Her finger and toe clubbing continues to progress. I'm happy to share photos if needed. But where we are is that we're still trying to find disease control. My belief is that the imapalumab helped her get the systemic control she needed to help the lungs clear up a bit. But, you know, it was too soon to tell. And we hope to repeat another scan the next time we go back to Cincinnati, which with the pandemic, we're not so sure when that's going to be, but hopefully in the next, calendar year.
So, and you're also looking to start a JAK inhibitor, correct?
Yes, to be completely honest, and hearing a lot of the suggestions, it's quite a challenge. My insurance company is giving me the runaround. They didn't want to approve Alaris. They don't want to approve Xeljanz. So now we're about 8 weeks into this insurance battle, but I am very eager to start a JAK inhibitor.
Okay. Anna, I see you there. Anna, can you just go next and describe summary where you are and what you are wanting, what's your questions about the next stage?
Sure. So my daughter Sophia is the one who's trached and vented, and she has a fair amount of lung damage already. And the problem that we are facing with her is her labs seem to indicate her SJIA is under control. Clinically, that part of her looks okay, but she continues to have lung inflammation that we just can't seem to get under control. She's on a biologic, she's on IV and oral steroids, she's on cyclosporin, she's on a JAK inhibitor. We're adding IVIG next week. And so I'm trying to figure out, I feel like we're kind of at the end, at least in my knowledge, of the known options. And we can switch out the JAK inhibitor and see if that helps. But I'm looking for information about what other options we have for her.
Okay. Any questions? Any clarifying questions that you want to know? No. Okay.
Not yet. No.
Not right Amanda, I see you there. Do you want to just describe what's going on with you? I know she's in the hospital right now. So, yeah.
Yeah, so hi everyone. My daughter, she received Gamifant pretty much in the first 2 weeks after her diagnosis of the ILD. And she was quite stable for a very long period of time. She had one flare last year in October of 2019. We did a CAT scan of her lungs and noticed that there wasn't a lot of improvement in terms of the inflammation, but much clearer in terms of like the actual air sacs and PAP, all those things that we were also seeing along with the ILD definitely showed improvement. So we were working after October 2019 to start weaning her down because she was doing so well on some of her medications. So she went down very low dose of daily oral steroids. She was slowly being weaned down on her biologic. She uses anakinra. And we most recently got down to just 20 milligrams of anakinra and 1 ml of daily oral steroids. And a couple weeks ago, about 2.5 weeks ago, we started noticing that she would be complaining that she was sore, she didn't feel good. But typically in a flare scenario with her, we would start to see respiratory symptoms gearing up, and she would need increased oxygen. She is on oxygen, half a liter all the time, but her saturations are pretty good. Like, in fact, very, very good. We probably don't even need to keep her on oxygen all the time anymore. It's like 98 to 100%. So because there was no respiratory symptoms, we just kind of thought, okay, maybe we'll up the anakinra again. Maybe this is a response to trying to get down off of anakinra. We went up from 20 to 30 milligrams, no improvement, was still complaining that she didn't feel good, that she was sore. Then we went from 30 to 40 after we did a round of blood work. Her inflammatory markers like ferritin, sed rate, CRP, those things were elevated, but her other blood work, like her blood counts and some of the other blood work that we had gotten back, was very normal. Her blood work has been consistently normal for over, well, close to a year now. And so we didn't really think anything of it. We were like, all right, we're going to just keep the course, increase the anakinra, try and go back to the dose that we were on. And that was 40 milligrams, see how she does. And last week, we started noticing that like there was not going to be an improvement. She just kept complaining more and more. She was having low-grade fevers. And then at night, we started noticing when she was sleeping, her saturations were not very low and not major desaturations, but low enough for us to notice that something was going on and that maybe she needed to like implement a sick plan where we run BiPAP if we need to at night. So we decided to get more blood work a couple days ago, and her blood work showed increased elevated inflammation markers, and her blood counts were all over the place. So she has high white blood cells, very low red blood cells. And as a response to what we were seeing, the team of doctors here thought it was probably best to pulse. And our scheduling situation with trying to get into pulse and COVID restrictions in an outpatient clinic, it just did not work out that we could get Lily into a infusion center to get pulse as outpatient. So last night we had to move her inpatient in order for her to get a pulse, which it's actually more beneficial that way because she was able to get stat labs and chest x-rays. We're still waiting on labs, but we did get the chest x-ray. We see some more inflammation than her last x-ray, but her last x-ray was much more improved than last year's x-rays. So we know that there's some inflammation going on. We're seeing that in her saturations. And now we just are waiting on the labs to see what's next. We are going to increase the biologic, and we're going to go back up to a full syringe, 100 milligrams, just to get us through for right now and see if it's the biologic. With the help of the pulse, hopefully that will stabilize her fortunately, she's in really good spirits, and you wouldn't really know looking at her that she is like having this internal flare and having some of these respiratory symptoms. So we're just trying to keep her stable with a med increase.
Yeah. So to summarize, you received imapalumab very early after the ILD diagnosis, had a year and a half of stability, and started reducing both the steroids and then the anakinra. And then in the last 2 weeks, you are in a big flare, and you landed back in the hospital with both systemic and lung issues.
Right.
Can I ask a question? Because it's unclear to me how long your daughter received the imapalumab.
So she received the Gamifant on compassionate use. She got, I want to say it was 15 total doses. Every 3 days she would get a dose. Because it was on compassionate use, she was not receiving the Gamifant in the same protocol that some of the other patients are receiving it here in the US. So she was getting plasmapheresis right before Gamifant, and I think she was on Gamifant for a longer period of time than some of the other patients here in the US.
So she was on Gamifant for, if it is 15 doses every 3 days, it's 45 days, which is 2 months and a half.
Yeah, she was in the hospital for 50 days total.
So that's longer.
Yes.
Than what is done in the MAS SJIA protocol, which is 4 weeks. Okay.
Yes.
And a significant improvement in the chest X-ray was found.
Yes, it took a while to see those improvements, at least in the chest X-rays, but there was definitely improvement in the X-rays. Post Gamifant a year later, in the CAT scans, the CT scans, we were seeing, unfortunately, not as much of the inflammation improvement that we were hoping for. We were very hopeful, based on some of the other scans that we had heard about in other patients, that there would be very low levels of inflammation, or much lower from what we had seen before. We didn't see that, but in terms of clarity in like what was there in the CAT scan, there was some improvement.
And the quality of life and the oxygen requirements.
Huge improvement in her quality of life, and the fact that she really only needs a half a liter of oxygen at her baseline to be the normal 3-year-old that she wants to be is like, that's huge for her.
So I simply use your example to highlight the fact that this is things which is going on. I'll call it these things which is going on in the lung will take a longer time, a significant longer time to resolve in response to any treatment that I can think of, compared to an acute episode of MAS. This is my take of what I've seen and what I've heard, and I wonder whether Alexi would like to. I saw Alexi. I see Alexi.
Yes. I think again,
from a clinical point of view.
Yeah, we have the same feeling. I don't think we have enough strong data to sort of support this statement, but the gut feeling is that you are right. I would like to clarify, what was the specific indication for Gamifant here? Was it just a lung disease, or there were features of macrophage activation syndrome as well?
That's a good question. So she did have macrophage activation syndrome. I think it was Anna that had mentioned her daughter had like a big sick where she went into multi-organ failure, and that was the same thing that we witnessed with my daughter. So in a very desperate attempt to save my daughter's life, we were talking to doctors about HLH. They kept using HLH as the term instead of macrophage activation syndrome. So when we heard HLH, my husband had saved an article about Gamifant. I don't even know why at the time, but as soon as we heard HLH getting used as the term to describe what was happening with my daughter, we asked if it would be possible to try and use this new medication, Gamifant, to stabilize her, because we were throwing the kitchen sink of medications at her in a very short period of time to try and save her. And that was how we ended up getting Gamifant, was because of this macrophage activation syndrome, multi-organ failure situation that we were in. But they were just referring to it as HLH, which prompted us to ask about Gamifant.
And the chest CT scan, the follow-up one that showed some improvement, what was the time period between the last dose of Gamifant and the study?
The last dose of Gamifant so she had her last dose of Gamifant and a scan, it was 2 to 3 months after that. And then we repeated the CAT scan just this past year, and again, we were seeing the improvements. So within a few months, improvement, and then stabilization and continued improvement through the following year. However, she did have the one major, I'll call it a major flare post Gamifant use in October of 2019. And our pulmonologist seems to think that the reason why we did not see the changes that maybe some other patients were seeing in terms of the inflammation on the scan had more to do with the respiratory flare that she had in October of 2019.
Got it. So Amanda, what are your quick questions now? And then we'll move on to the next patient.
I guess my biggest question is just related to the use of pulse dose steroids and frequency of that. We keep going back and forth between if this is macrophage activation syndrome gearing up, should we be giving just 1 pulse, 2 pulses, 3 pulses, or is there a possibility of, we're waiting on CXCL9 numbers and IL-18 as well, using Gamifant again if this is another thing that's going to spark into a respiratory flare as well. Those are my 2 big questions.
Yeah. Okay. I will want to move on to Rosie. Rosie, you there?
Rashmi, she's upstairs with the kids. Can you hear me?
Briefly summarize, Andrew. Yeah.
Yeah, so we were going through a flare in September of this year. Her CT scans before were looking really good. And we did a 10-dose trial of Gamifant, which ended on October 16th. Now, afterwards, in the last 2 months, her lung usage improved. She was down to half a liter of oxygen. Now, in the last 2 weeks, we've noticed an increased amount. We were in the hospital on Monday, and they decided to do a chest CT there, and it was about as bad as it has ever been. And her oxygen use is up to now 4.5 liters. And we're about 2 months out. They also found cysts on her lungs, which we've never seen before. And this is, 2 months after the Gamifant usage.
And if I can just add some context, so, your child had a pretty rocky beginning of the year with lots of other things going on as well. And then
this spring in May, we decided to do a full lung lavage in Cincinnati with Dr. Tao. And while we were there, she had abdomen swelling, and they found NTRK spindle cell sarcoma in her small intestine. So they removed 60% of her small intestine and 30% of her large. So that's a complication on top of everything else, SJIA-wise. And there have been no conclusions to any of that, but over the summer, her lungs improved very well in response to that lung lavage. We were down to half a liter of oxygen for a long time. And just recently, in the last 2 weeks after this Gamifant treatment, she's drastically needed more oxygen. And all our information is gathered, and they're deciding on treatment. Right now, we're on Xeljanz, 2 doses of anakinra a day, and about 18 milligrams of oral steroids.
Yeah, if I can just add a comment, I know Rosie very well. We talk very often, and I followed her very closely through all this. So I think Rosie, they had a very tough beginning of the year. Then the SJIA and MAS flare ended up. So no, then the lung lavage that made things better. Then again, the flare later in the summer with the SJIA and MAS. Then received Gamifant, saw a lot of improvement. Then and that was about 2.5 months ago, and now again deterioration has started. So what you're seeing is like, kind of improvement after lavage, improvement after Gamifant, but much faster deterioration than what you saw maybe in the previous patients.
Yeah, she's on more oxygen now than she was before we did our lung lavage in May. So we feel like overall she's worse than she's ever been. Now, clinically, her labs, her ferritin was 32. Her other labs all look fantastic. So from a lab perspective, she looks really good. We are waiting on IL-18 and CXCL9 labs right now, but she looks really good from the lab side and really bad from the clinical side.
Okay. We'll try to just address an overall questions on an overall level as to some treatment ideas. Emily, you there?
Yep, can you hear me?
Yes, we can hear you.
Okay, good. Are you able to see me?
No, we don't see you yet, but we hear you.
Okay, well, I'll just start talking anyway. So my daughter Veda was diagnosed about 5 years ago. She's always been refractory, always uncontrolled, switched from meds to meds. This summer, she went into one of the worst episodes of MAS, and she's been in MAS multiple times.
Emily, can you mention the ILD diagnosis when that happened?
Yeah, yep. So we are in Minnesota. Our rheumatologist recommended us head to Cincinnati about 1.5 years into Veda's diagnosis, just because we were really running out of options. It was at that visit with Dr. Graham, again, about 1.5 years into diagnosis, that she was diagnosed with the ILD, which has since progressed to PAP. And so this, like I was saying, in June, she went into the worst episode of MAS she's ever been in. For the first time, she required lots of blood products. And after probably 2 weeks in the hospital and the typical course of treatment not working, she was also given emapalumab. Since then, so all these other parents are so good with like exact dates and how many rounds that they got. I don't remember exactly how many Veda got. I want to say somewhere around 8 doses over 8 weeks. It was like every 3 to 5 days based on labs. Since then, Veda is doing amazing. She's more controlled than she probably ever has been. I should also mention, while she was in the hospital, she had increased oxygen needs, which has never happened. She's always, she's had the ILD, the PAP. Excuse me. Her PFT 6-minute walk tests have always been beautiful. She really shows 0 lung symptoms, but on imaging is when you can really see the disease activity. We've not had any imaging done post Gamifant. She's due for that anytime now. We're about 5-6 months out. But like I was starting to say, she's doing wonderful. She has more spunk and zest than she's ever had since pre-onset. One thing that we have run into is liver involvement now. Liver functions look beautiful. However, on imaging, she was diagnosed with moderate to severe cirrhosis, and we're in the very beginning stages of considering liver transplant at this time.
Yeah. So what are your questions, Emily?
Like a lot of other moms, one of my biggest questions and goals is to get off the steroids, because a secondary issue of steroids has hit Veda hard, with fractures, growth issues, the list goes on. And I guess biggest is steroids. We always want to get our kids off steroids. And I guess liver is a huge thing right now.
Yeah. What about imapalumab? What do you think about that? And would you like to do it again? Do you think she'll need it again? What's your gut?
Yeah, I mean, all of these medications that we give our kids come with some sort of side effects. For Veda, the imapalumab she had some high blood pressure that they watched very, very closely. As soon as she was done with her last round of imapalumab, within weeks that normalized to her baseline. And the results that we've seen from imapalumab are amazing. We have never had this control ever, and we have tried, we've tried Actemra, Ilaris, Orencia, mycophenolate, methotrexate, cyclosporin. You know, we've tried so many things. We've never gotten to where we are right now, and I am so pleased to see how Veda is doing. And I know that other families do really well, and then 7, 9, 12 months later, they start to see a little bit of a blip up, and they either need to be redosed or like Regina. I know Jules is starting to struggle again. And so our rheumatologist team here in Minnesota is ready and willing to fight for another dose of Gamifant if and when we see that for Veda.
Emily, can I ask you one question? I remember in the summer of 2019, your doctor was struggling with a CMV infection. Remember?
Yep.
It was
Yes.
a very, very difficult balance, right? Your daughter was immunosuppressed, and each time she would develop signs of MAS, they would increase immunosuppression, and that would bring the CMV infection very active, and then you would go down on immunosuppression. You would do better with the CMV infection, but the MAS would come back. It was a sort of a very, very difficult balancing act that Dr. Iskala had to perform, I think. So that was the summer of 2019, correct? When
Yep.
you received Gamifant in June 2020, correct?
Correct.
Any issue with the CMV infection during that period of time? Do you remember? You were on ganciclovir prophylaxis, I believe, correct?
She still is. She has never been able to come off of valganciclovir.
What happens if you miss a dose of
when she is off of it, we start to see, they monitor her CMV level, viral load often. And when she comes off of it, we start to see that viral load spike.
Is it clinically significant usually or not?
No, they just, because it was the suspicion of a MAS trigger in 2019, they just don't want to take any chances. She really has zero side effects from the valganciclovir. And so at this point, it's just in our best interest to keep her on it. So she's still on it to this day. She's been on it for greater than 1.5 years at this point, I think. And they're still monitoring CMV levels, especially after Gamifant, and the concerns that it could reactivate CMV.
All right, thank you. And another question I wanted to ask, there is sort of, if you look at the chat box, there is discussion about using Cytoxan in this patient population. So, and I'm not sure who exactly is bringing this up, but any in this group, what do you, any experience with Cytoxan?
No, we don't. Can I go back to Mrs. Schumacher and
Yes.
ask another question? She just deleted herself from the video. We met, you might remember we met in the summer of 2019 in Cincinnati.
I do.
What is this liver issue? Have you ever had any problem with liver function tests in the past?
No, so we've always watched her liver functions very closely. Sometimes they'll hang out a little bit on the higher end of normal or just outside the reference range. On exam, and I'm sure Dr. Graham, well, maybe Dr. Graham remembers, her liver is large.
The question is for you and Alexia as well.
Well, unfortunately, Mona did send me some imaging reports, and it was not very, very clear. And there were discussions about possibly proceeding with a liver biopsy. Did it happen or not at the end?
Yes.
It did happen. So there is we have biopsy results.
There are biopsy results, and it was based off those results that the GI hepatology team at the U of M decided they would like to proceed with transplant.
I think Alexei, you should see that biopsy.
Yes, I have not seen the result. I knew that. Mhm.
Emily, you should maybe email or that I can help you.
Yeah, our team is in the process of trying to close those loops, and you are definitely one of those loops, Dr. Graham. So if you hadn't heard already, it will be very soon.
Okay, so we've heard from a few patients, which will help you maybe understand the range of issues that we are seeing and kind of the questions that are coming up. If I've missed any patient, I'm sorry.
Rashmi, I see that there is a discussion about cytoxin. I would like to hear sort of parents who have experience, from parents who have experience with cytoxin, sort of what's their impressions are.
Okay, I mean, I'll start quickly say we did it right after the diagnosis of ILD. First intervention they actually did. First thing they did was to try to take off anakinra, and then he went into MAS, so we had to bring that back. And the second thing they did was to start cytoxin. We did that 6 months. We relatively event-free, didn't really have any side effects or issues. His lung disease, did not progress for like a year or 2 years after that, after which we came to Cincinnati, and then the disease progressed about a year after coming here, Alexei. So,
what about other patients? Because I see in the chat box, there are quite a few patients that seem to be treated with cytoxin.
Yeah.
We also had the 6 doses of cytoxin, and my son had lots of side effects because of that. He also elevated the GI issues. He was throwing up, and that's why doctor decided to stop the medication. And also we put the Ilaris on hold while doing cytoxin. We also holded the Ilaris. And then my son became very sick, so we had to continue Ilaris along with cytoxin. That happened for 5-6 months, and then his lungs were quite stable with Ilaris and azathioprine. And probably 8 to 10 months we were seeing his lungs were stable, and again he was flaring up, and his lungs disease progressed, and we saw lungs disease PAP later then. And then we tried tacrolimus. That didn't work, and now he is on JAK inhibitor along with Ilaris.
And what do you think?
It looks like he's within 6 months he had bad flares of coughing, and again right now he is coughing badly and looks like his lungs are not stable. So we are asking for CT scan, and we will see how it goes. But his lungs doesn't look stable at this point.
Thank you.
There's a question about CXCL9 and IL-18, and that's from Pauline. Does anybody have any comments about that?
I think we should ask Fabrizio.
It's always me. I think CXCL9 has to be considered a direct biomarker of activation of the interferon gamma pathway. At least this is my understanding. IL-18 is much more complicated than that. IL-18 is being produced by stromal cells, and also by stromal cells, I mean cells which are in tissues all over the place, and also by immune cells. And we don't understand exactly who is inducing what. Some data shown by Grant today show that actually interferon gamma was inducing IL-18, but in general, we think that IL-18 predisposes to higher interferon gamma production. So if it has high IL-18, that might simply means that the disease process behind the disease is still active. The disease may be very well controlled. Bas has very good experience in patients with, the very well controlled disease and high IL-18 levels. And we're trying to use this to guide drug tapering in the patients. CXCL9 is more of an indication of mass interferon gamma MAS related processes. Alexi, did I answer? Not sure.
Yes, yes, and I very much agree with you.
Okay, great.
And if I can just, kind of, I think Pauline is actually, as her team has suggested, or maybe she's been discussing bone marrow transplant, and I know she has some questions about that. And Pauline's history is that history of MAS, and was diagnosed with lung disease maybe about 2 years ago, if I'm not wrong, and has tried a bunch of different options, including going off the Ilaris and remaining just on the cyclosporin and the JAK inhibitor, but then had to bring the biologic back because child was flaring too much. And currently, I think the question is that what's the next step, and whether it should be bone marrow transplant. Correct, Pauline? Did I summarize that correctly? Yeah.
Yeah. Right now, we stopped the adding the Ilaris back again because of the COVID situation. So, but what I've seen after the COVID is that it looks like the new dose of the Xeljanz is starting to working again because her labs are better than like 3 months ago, and her rash, that was the main issue of taking her out of the Ilaris, is basically gone again. So now we're waiting for all this COVID situation goes through to back in the conversation of adding the Ilaris again. That's something we will be discussing in January when we go to Cincinnati again. But our main talk right now is going ahead with the bone marrow, because for us, it's been like 8 years now. We haven't really achieved disease control. We've tried many treatments, and our last option was trying the Xeljanz, and still we haven't had that disease control that we were expecting. So for us, all the side effects that we have been seeing of all these treatments, especially the growth situation, and her lungs doesn't show any improvement, that's why we are strongly considering the bone marrow. And that's our biggest concern right now. And especially if after the new pulmonologist that we have been seeing, he was telling us that her lungs just can't wait any longer. We need to control her disease because her lungs are getting worse. So that's our biggest fear. So that's why we're considering the bone marrow.
Yeah. And just to give you a background, there's 2 patients in our lung group who have gone in for bone marrow transplant. One is patient went in for that about 2 years ago, had a very tough year, and she had more of a pulmonary hypertension, didn't have actually, wasn't diagnosed with the PAP at least. And it was really tough the first few months after transplant, but since then she engrafted completely, and she's doing really, really well now, has moved back to Brazil actually after family was able to move back. And the other patient is in Canada, and they did emapalumab, etc., and it helped them actually get ready for transplant. And she's undergoing that right now, so we don't know what's going to be happening there.
So Rashmi, do you happen to know what her lung status at the moment? Is she requiring oxygen supplementation? And
she was very sick for a while. She was I haven't I think she was intubated after the transplant for some time, but then I think had recovered from that. I haven't touched base in the last 10 days, but I would guess so, given what the situation was when she went in for the transplant. So I'm curious what the doctors think about the option of transplant for for these patients.
Well, the experience is very limited, and I think somebody brought this up the other day, that sort of we still think about the risks associated with this procedure that existed many years ago, and things are changing right now. The bone marrow transplantation protocols are improving. So So I think probably we should organize a meeting, Rashmi. I don't know how we could do it, but maybe invite somebody who is an experienced transplanter and understand. We need to understand the risks better. Okay. As a rheumatologist at the moment, I'll be honest, despite the fact that I'm working with the BMT people, I still don't quite understand what the risks are. So I think this issue needs to be revisited.
Okay.
Maybe sort of one of the to-do items would be, in fact, to organize maybe a little teleconference with experienced people from a couple of centers, and that probably should include, by the way, Holland, Utrecht, and again, to understand what the risks are. Okay,
understood. One more specific question. So I think several of the patients that you've heard from have gone on JAK inhibitors, and including tofacitinib. I wanted to refer back, Alexi, to that case study from France, where they used a different JAK inhibitor. And if you wanted, and we got an update from them as well, that the patient is actually doing well. I believe this was ruxolitinib. Do you want to comment on that? I know it's just one case.
Well, again, theoretically, sort of based on what we have heard today, we think that interferon gamma does play a certain role, perhaps type 1 interferons, perhaps some other cytokines. So the question is, do we target just one cytokine, or do we go for several at once? And if we believe that blocking several cytokines would be beneficial in these patients, then JAK inhibitors certainly could be a good option, right? And the question is which one? And at the moment, tofacitinib has been approved in pediatric rheumatology for polyarticular juvenile idiopathic arthritis. And technically, since systemic JIA is still called juvenile idiopathic arthritis, we easily can request the company to approve this drug on this, just on this basis. So it seems to be a little bit easier to get this drug covered by the insurance companies. The trouble here is that we have only 5 milligram pills, I believe, right? So we are very, very limited in terms of how we can dose. Ruxolitinib, in contrast, has been used and approved for graft-versus-host disease, and it has been specifically tested in very, very young kids. So there is a liquid preparation, and there is quite a bit of experience with how to dose it properly in the pediatric population. However, it is much, much more difficult to get it approved by the insurance companies. So I think it was the theme of this discussion today. Clearly, I think there is a group of patients with refractory systemic JIA who are very, very likely to benefit from this treatment. I don't think we still have reliable biomarkers that could identify this particular patient population. And again, it's still an open question which drug is the best. Fabrizio, you had some strong feelings about the choice of JAK inhibitors, correct?
No. I just want to emphasize the concept that this is a very different treatment. So if you target a cytokine with, either an IL-1, IL-6, interferon gamma, whatever cytokine inhibitor, you're using a very simple principle. You overload the body with a huge amount of drug that will completely neutralize the effect of the molecule. So you get rid of TNF, you get rid of IL-1, you get rid of IL-6 completely. When you do use JAK inhibitors, you don't target one pathway, as Alexi was saying. You target multiple receptors of multiple cytokines. And it's approximately 60 different cytokines. Some of them are very much used for very vital and essential process like immune response, making cells in the bone marrow, blood cells in the bone marrow. Growth hormone uses JAKs, okay? So, and we know from mice that you cannot get rid of JAKs. So if you do make a mice genetically deficient for interleukin 6 or interferon gamma or IL-1, the mice are fine. okay, unless you challenge them in very specific ways. The mice are fine. The mice in which you try to attempt this same process, knocking out completely the genes for one JAK, and there are 4 different JAK isoforms, they either they die or they have a very severe phenotype. So when you use a JAK inhibitor, you're not inhibiting completely. You are trying to, like, dimming the light in your living room, okay? You never want to go to completely dark. You're just dimming it. So I guess the point that Alex is making, which I strongly agree with, is we don't have a biomarker because we are inhibiting many things, okay? Not as many as we do with glucocorticoids, with steroids, okay? Not as many, obviously, much more specific, but still a little bit unspecific. And we have to fine tune the dosing so that we get an equilibrium between the effect that we want to get and inhibiting too much. And I think Alex has a point. There might be patients who might benefit of this, and I'm pretty sure there are. Unfortunately, we can't get them, so we can't use them. We have tried to use a little bit of Ruxo, but it's complicated for us, very complicated. And Tofa is not here. And the other thing is that they're not the same, Alex, as you pointed out. They inhibit the different forms of JAK, the different forms, with to different extent. And so it's very difficult to go from one to the other, knowing exactly what to expect.
Well, Hermina is running a clinical trial of baricitinib. Yeah, so we'll see sort of that we will have some results very soon. And also in the tofacitinib clinical trial, again, the inclusion criteria were, I think the patient was supposed to have polyarticular course of JIA. And as far as I know, there were about 20 patients with systemic onset. If I remember correctly, her presentation at one of the recent ACR or press meetings, there was some response in that subgroup of patients, but not all of the patients responded. I think it was probably about 50% who showed ACR 60-70. So I think that the data is coming. And I think that particular study did involve sample collection, as far as I know. So there are samples that could be probably used to look at the biomarkers. So the data will be coming, I think.
So I posted this in the chat, but I really wanted to invite other physicians, or even, you know, are there other therapeutic angles here? Somebody mentioned T-cell based therapies at some point, I forget when, but are there other things to try? Because I mean, as you can see, there's all the things that are being discussed now have been tried by several of the patients, and imapalumab definitely seems like it makes things temporarily better, but then it starts coming back, and maybe we need a different dosing regimen there. JAK inhibitors seem to help a little bit to some people, including in my case, but it's not resolution. So are there other classes of drugs that we haven't really thought of so far?
Before we move to another drug, I'd like to point out the fact that emapalumab has not been given for a longer period of time to have had a persistent effect on the process. So 1 month, 4 weeks, it's by far, for me, not enough. So we need a trial, we need a different dosing regimen, definitely. We need a longer treatment, and this longer treatment has been used already in different instances. We have a patient with SJIA lung disease 7 months on emapalumab, 8 months almost now on emapalumab. We have had a previous patient treated for almost 7 months, and there is one patient who has been treated for 1 year, and there has been patients who have received it for several months. So I think we really need to gather the evidence whether this is effective or not, and some preliminary data do suggest that this is the case, but 4 weeks is by far too short.
Correct.
It's possible that there's some people from SOBI here. I hope they are hearing this. It's one question, a follow-up question. So you would recommend something like once in 2 weeks for a few months? That's like kind of your off the.
No, I have no. This is don't make me guess things that I cannot.
Sure.
We have been using in our child. We've been using every 3 days for a while, and then switched to every week, and then to every 10 days. then every 2 weeks. And it's a trial and error thing, but we need some PK data, real PK data from this, from
Correct.
Otherwise, it's
is there any experience in the group here of rapamycin, sirolimus, with in this disease with mTOR inhibition?
Well, not in the lungs, but sort of what I've seen recently quite a few patients coming for a second opinion with recurrent MAS, and I have a feeling that the West Coast in particular, they prefer sirolimus rather than cyclosporine for kind of prophylactic treatment against MAS, if you wish. I certainly have seen a few of those kids, and I mean, hard to tell, but it looks like it may be helpful.
So it's interesting that you bring that up. When we first got diagnosed and we were back in Stanford, our pulmonologist had actually suggested that for the lung disease aspect. And over the years, we've discussed it with Dr. Grom several times on and off about the MAS aspect. And I sometimes wonder, is that, that's used for lung disease and for ILDs of different kinds. And it's used in some places for MAS situations, like in Castleman disease, I know they're using it, which is another cytokine storm. And is it, I don't know what the safety profile is. Is it worth trying in some? I don't know. I'm curious.
No questions. There are quite a few kids around in the country who are getting this treatment, mainly sort of for MAS prophylaxis. And again, if I remember correctly, quite a few of those were from Seattle. So we may ask some physicians there. Troy Torgensen would be a good person to ask.
Yeah. I see on the call, I believe Dr. John Bosnack, who's from Utah, and I know he's one of the treating physicians of Anna. Did you have any questions? I want to make sure to give a chance to any clinicians who are on the call who are treating these patients if they want to add some comment or ask any questions. No.
You're asking me?
Yeah.
I enjoyed this conversation immensely. It seems to me that gamma interferon inhibition, as Dr. DiBenedetti said, we need to try this in a trial. And we'll find, I bet we'll find, like we did with some of the other biologics, that it'll work great for some, and then there'll be another group of patients who don't seem to respond, because my suspicion is this is a disease that has a lot of different underlying pathophysiologies, but we're all get our own opinion. I would also mention that I've had one successful autoimmune bone marrow transplant in a patient years ago, and I've not written it up because the patient was diagnosed with Still's disease by another physician and came to us in MAS, and after we got her through the MAS, we did the bone marrow transplant, but it was a haploidentical sibling, and that's one of the problems with bone marrow transplant is I don't think they've done alloimmune unrelated or haploidentical, sorry, this was an identical sibling with haploidentical patients. So this is, there's still a lot to learn about it. And I also agree with Alexa that we're probably thinking about complications that occurred years ago, and we're probably doing better now.
Any other comments? I see, from the other doctors who are here, if you want to add any, it's starting to run out of time. Dr. Schuler, do you have any comments? Some of these, you're familiar with some of these cases. I'm going to raise one question. It's not directly a question about treatment, but there's, I think, so right when we got diagnosed, and this was earlier in the disease, that was 7 years ago, we were told from the beginning that you need to get a lung biopsy done because this is a rare disease. And at some point you'll want to know what was there in the beginning of the disease, not after there's a lot happened to it. So while my child did not have any lung symptoms, he was very stable from a lung perspective. We talked to many experts before doing this, but we ended up having a biopsy done. And I'm very glad because it was a one-day stay in the hospital. We have his lung tissue, and I see it as an option to try to find the right drugs. And in the last few years, I hear that you can now diagnose this disease without a biopsy. So we have stopped doing biopsies, but biopsies are not just for diagnosis, they're also for this, which is a very rare, high mortality rate disease, to try to help us find what are the cells gone wrong, how do we help with these drugs, which drugs. So do we not see biopsy as an important tool in trying to help the patients?
Rashmi, you're absolutely right. In Cincinnati, I think there is a trend to do biopsies less and less if we see sort of a very characteristic feature on high resolution chest CT. I would like to ask Vivian. In her presentation, she mentioned that actually they see very little correlation between the imaging and the biopsy findings. Is it correct? So do you still feel that a biopsy would be necessary for all of these patients? Vivian, what could you comment on that statement that you made?
No, we don't see correlation between the imaging and the biopsy findings. I'm saying that when you take the imaging by itself without the clinical context, it doesn't give you a pathologic diagnosis. So I think that's pretty much a truth. So when we have the full constellation of features, that our expectation is that the biopsy would be PAP. Our pulmonologists, just like yours, don't necessarily biopsy. We do, however, continue to do the bronchoalveolar lavage just so that we are not missing particularly any infections that would require attention.
So you do it mainly to rule out infection, correct, in those patients rather than...
Yeah, and that's what the Child Network has been, that's been so helpful, and that Chris Tao is part of that, that they still are concerned. Now, we haven't really been finding infections, but we still, our group still feels that that's important. That's far less invasive than doing a lung biopsy. So it's interesting to hear that, I understand, Alexei, that you're not necessarily then going to biopsy if you have the full constellation of findings that are associated with the PAP diagnosis. I think it's interesting that in those with the HLA association, that all 20 of those with diffuse lung disease that were biopsied, and they had features of delayed hypersensitivity reaction, that every single one of those were PAP. So I think that, again, if you put together the clinical phenotype, you begin to strengthen the suggestion that you don't necessarily need a biopsy. I'm not sure if that's universally accepted. But
again, it's a trend. I'm not saying that it's a rule here, yeah, but it's a trend.
But it's our trend matches your trend, particularly if you see the sort of full clinical phenotype. Are you guys not doing BALs for infection?
Less and less, I would say. And again, most of our patients are on, well, all of our patients are on prophylaxis. So we...
What kind of prophylaxis? You're talking PCP prophylaxis?
Both, yes. So we were certainly PCP, but also antifungal prophylaxis.
Also anti-what? Fungal?
Antifungal, yeah. Mm-hmm. For some, depending on, for example, if I start a JAK inhibitor, I get a phone call from my pharmacist immediately who insists to start antifungal prophylaxis in addition to PCP prophylaxis.
What are you using for that?
Well, the last time we actually used voriconazole with a not a very good outcome. So we replaced it with something, but I don't remember what it was. We'll send you an email with that.
Okay, yeah, please do. Thank you.
I would say that in the patients that I've seen recently, I do push for at least an initial bronchoscopy, mainly for infection, et cetera. But yeah, the biopsies, unless there's atypical features, both clinically or imaging or otherwise, we've been doing it less and less, and certainly following those sort of child sort of guidelines, which is that in a patients who have sort of progressive disease or treatment refractory disease, being more where to consider a biopsy than at the beginning when it's first detected. But I do think there is a role for bronchoscopy. I think over the last 6 to 9 months, it's challenging, right? Because patients don't want to come in. They don't want to come into the hospital. Patients that we're seeing further away don't want to come here for the evaluation, but don't necessarily have somebody closer to home who's has seen patients with rare lung disease who's comfortable doing it.
So we are running out of time, but I want to, I think it's okay to take a few minutes more. If we have any new different ideas from the physicians, if there's something we haven't discussed that is worth at least keeping in mind. If anybody has anything to share, please do.
I have a question. This is Mike Umbrello. So I might not have thought about this lung disease as much as the people at the centers who are seeing you and your families and your children all the time. But to my colleagues, do we think about this mixed heterogeneous pattern of pathology in the lungs in some process sort of way? Is this dysplasia? Is this metaplasia in a developing lung? How do we conceive of what it is that's happening differently in multiple different places in the same lung of the same person with the same genetic background and the same exposures?
What we see is inflammatory process that starts in the interstitial space, that damaging, and then we sort of see remodeling with fibrosis.
And so those things explain the 7 different distinct patterns that were described in the paper.
What
when
are
you say
7 different types you are talking about? CT scan findings, or
it was corollary of, I believe there was CT and pathology correlated, and there were some places where there was convergence of CT with consistent pathology findings, but there were others that weren't. This is actually in combination between the 2 different papers, but it seems like there's a wide number of patterns of lung pathologies. And I'm just wondering.
To me, there is a unique pattern that is shared by all the patients. We just may be dealing with different stages of the disease. But it's
in different parts of the same target organ, Mike. I think Alex has a point. Different stages of a process that obviously is not synchronized in every single part of the target organ. This is the way I see it.
Yeah, and I'm looking at the combination of the pathology, which is, the specific histology that you can see under the microscope compared with the CT patterns. And is that what you're asking, Mike, on how those come together? Or are you talking about different pathologies that you're seeing on a biopsy? Because we're not finding fibrosis. We're not seeing traction bronchiectasis on the CT. So I'm not quite understanding what you're asking, actually.
It seems like between the 2 papers that were published, there are a group of distinct pathologic features, which Fabrizio has just suggested are part of a continuum, a temporal continuum.
And that's
one explanation that does make sense in my mind.
That's our explanation. Mm-hmm.
Okay, I was just wondering if in the developing lung, if we need to think about something else related specifically to development, either dysplasia or metaplasia, as a part of this process. But obviously, I'm.
And then, so you're talking about the younger patients as well, because we have a variety of ages. So what you're talking about in the developing lung, you're talking about younger children rather than older.
Yeah, prior to the age of 12, when arborization is reaching its terminal stages.
Right, because we have patients that are older than that. So this is not just a disease for the very young.
This is Betsy. I just want to say one thing in relationship to the question that you're bringing up. I do think that when I've talked to the lung pathologists, that the extent of fibrosis is less than what they would, the extent of fibrosis is less than what they might expect, even over, even when the biopsy is done and after the lung disease has been going on for a while. And I think it's interesting that the biomarkers we're finding, the ICAM5 and MMP7, are biomarkers that are associated with fibrotic lung disease in adults. So I do think that in the children where this starts young and it's a developing lung, that there may be some consequence of a young lung responding to an inflammatory process differently, such that fibrosis is delayed because that lung is growing and changing And so I think, because I have found it interesting that the markers we found are so associated with, IPF, idiopathic pulmonary fibrosis, and scleroderma lung, and things where we think of them as a very pro-fibrotic process. And the fibrosis here is quite late stage, and et cetera. So I'll just stop there. But I think that the issue of a developing lung is interesting for what the pathology shows. And I'll just make one other comment related to Rashmi's comment, because I think that if I understood Rashmi correctly, there was a distinction she was making between, can we learn something from biopsies about the disease versus do we need a biopsy to diagnose the disease? And those are really, I think, two different questions. And the clinical practice, which may be appropriately moving towards doing fewer biopsies for the safety of children, et cetera, it is a different question than whether could we still be learning more from tissue, where I think the answer is yes. And so that's just...
Yes, that was the distinction I was making. And this was something that the doctors at Stanford, I think pretty much everyone I spoke to had guided me, and they had said, look, this is a rare disease and you will want to understand, there are precision medicine approaches down the corner, and you will not be able to understand the answer once you've had 5 years of this disease. And I was very well guided that when you have a rare child, you want to have a shot at finding the medications for them. And that is a different question. And, we spent 1 day in the hospital for a biopsy, and we've spent weeks and weeks for MAS. So it just seems to me that we have to remember this is a rare disease which has a high mortality rate, and we want every shot at finding drugs for these kids. So that was kind of my point. I think
collect as many data as we as everybody can, in addition to the biopsy.
Yes.
Yeah.
On that note, Fabrizio, the fact that we've had over 100 participants around the globe is really something that I think this community should be very, very proud of. And I really appreciate all the patients and the families who've participated as well. And of course, they can't be specifically acknowledged, but we really do appreciate all the involvement from such a large group of people globally. Thank you.
Yeah, thank you. Thanks everyone who's participated in this. I hope, I think the patient got a lot out of this. I'm sure they have more and more questions, and maybe they'll follow up with their own teams. And some of you who are patients of Cincinnati, maybe follow up there if you didn't have your questions answered. I'm sorry I was not able to get to every message I received during this. And thanks for very stimulating discussion for 3 days. It's been really intense. And the virtual format has proven that we can do something that we could not have pulled this off in real life, if we had done a physical event. So we've definitely learned a lot from this.